Welcome, everyone, and thanks for being on time for this. And again, forgive our 3-minute delay in beginning. We are thrilled to be able to present to you advocacy ideas for winning harm reduction battles. This is the second in a sort of fall series that we've done in terms of harm reduction advocacy that is supported through either our Southern Reach work through AIDS United or through the Funding Collaborative Syringe Access Fund. That has really sort of changed the landscape in terms of harm reduction advocacy, and we wanted to be able to share it with interested partners. So thanks for those of you who are joining for the second series, and then for those of you which this is your first, welcome and thanks. I know most of you know, actually all of you, I can see it from the list, know AIDS United, so I won't go into that, but I will spend a little bit of time introducing our speakers in the beginning, so we don't have to interrupt the presentations. But first, let's just go through a few logistics. So unless you're a panelist, your line is about to be muted.
The conference is now in presentation mode.
Great. And so that was the indication that now whatever you do, if you're sipping your Starbucks or typing on your keyboard or anything, that means we can't hear it unless you're a panelist. We unfortunately can't stop the beeps as people come in and out, and so forgive us for that. We're just working through that with our WebEx system. And as a result of your lines being muted, you're going to have to submit all your questions via the chat function in your webinar. If you have problems with that, please do send myself or Shannon Weiss an email, and we'll be able to try to do some technical support on this end while the speakers are presenting. For your information, this will be audio recorded, so if you're not able to join for the whole webinar or you know others who will want to join later, we can share the recording. And also your chat will be saved, so any questions that you submit versus in the chat function will also be saved, so we have also a written record of the various questions that were submitted in case we can't get to all of them. So with that, let me do quick introductions. So I'm Vignetta Charles, Senior Vice President at AIDS United, and I oversee all of our grant making. And Shannon Weiss is Grants Coordinator at AIDS United and makes sure that all of our grants are processed through our portfolio, but also has a particular interest and passion and hard work for our harm reduction portfolios. So thanks to Shannon for sharing the love of harm reduction with me, and thank you to our speakers. Our first speaker, and I'll run through the bios for all three, so don't start speaking, Roseanne, after I introduce you. Is Roseanne Scotti, who's the Director of Drug Policy Alliance in New Jersey and has managed various successful advocacy campaigns, including the Compassionate Use Campaign, which passed medical marijuana legislation in New Jersey. Before joining Drug Policy Alliance, Ms. Scotti was a research coordinator at the University of Pennsylvania Center for Studies of Addiction in the HIV Prevention Research Division. Roseanne is alumni of the University of Pennsylvania and has her JD from Temple School of Law. She's authored or co-authored law review and medical journals on HIV prevention and drug policy, as well as founding Prevention Point Philadelphia Legal Advocacy Project, amongst many other things. In 2004, Roseanne received the Award for Outstanding Achievement in the field of HIV prevention from the New Jersey HIV Prevention Community Planning Group. And in 2005, she was appointed to New Jersey's Gangland Security Task Force. So we're thrilled to have Roseanne here presenting on some recent wins and battles that happened in New Jersey. Sandwiched between two of our Mid-Atlantic friends is Robert Childs, North Carolina Harm Reduction. Robert Childs is a Southern-based HIV, hepatitis, and overdose prevention and harm reduction advocate. By our friends at thebody.com, Robert was named one of 5 people who made a difference in HIV in the USA in 2011, and we would argue that's true every year. He was also recognized for running the best U.S. grassroots campaign by the ADAP Advocacy Association in 2013. Robert's key skills include advocacy, developing sourcing income, program development, coalition building, turning around struggles, and leadership. Robert has, in addition to his experience serving as North Carolina Harm Reduction's Executive Director, he's also Operations Manager for Positive Health Project's Public Health Operations and Program Director for Positive Health Project as well. Robert's worked and is considered an expert in HIV and hepatitis, harm reduction and drug policy, drug user and sex worker health, syringe access, law enforcement, and drug user interactions, among many other things. Robert is also a veteran barbecue expert, and we're happy to soon be tasting some of his whole goat, I think it is this year, in terms of his whole animal roast. One of his proudest advocacy achievements was leading the campaign to the passage of SB 20, a Republican comprehensive overdose prevention bill, as well as HB 850, a Republican partial syringe decriminalization bill, and we'll hear about some of that today. And finally, last but certainly not least, Matt Curtis is Policy Director at Vocal New York. For those of you who don't know, Vocal is a grassroots membership-based advocacy organization that works to build power for low-income people living with HIV and hepatitis C, people who use drugs, and the formerly incarcerated. For the past 14 years, Matt worked to build harm reduction programs and supportive policy in Eastern Europe and Asia, and now has joined us over on the mainland in the U.S., and first as a staff at Open Society Foundations, and then as an independent consultant for projects supported by UN Office on Drugs and Crime, the World Health Organization, USAID, and others. Matt also has a master's degree in epidemiology. So those are our esteemed panelists, and I could actually go on and on about all of them, but in the interest of time, I will not. And I will now turn it over to Roseanne to start us down this path.
Thank you so much. What I'm going to talk about today is really some lessons learned from what turned out to be a really protracted, knockdown, drag-out battle for syringe access in New Jersey. It took us 5 years to get a bill passed that allowed for syringe access programs in New Jersey, and another 5 years for us to get over-the-counter sale of syringes, which we actually did last year, and Governor Chris Christie signed that bill, so that was very exciting to have that kind of bipartisan support. But, I looked back on this and thought, what are some of the major takeaways that I would have liked to have had, some of the major lessons when I started out, because when I started to do this, I can honestly say I didn't really know what I was doing, and I was really learning on the job, having done a lot of grassroots activity, but not really having done a lot in terms of legislation or lobbying at a state level. And, one of the biggest things I learned, and that I think is key for moving these kind of often tough issues, is remembering to make it about people and not about statistics, and that it's all about the story. I came from, a research background and, went to law school, which will, pretty much ruin you for just about anything else in life. And so, when I started doing this work, my information packet that I gave to reporters and that I gave to legislators sort of looked like a dissertation, and I had to learn very quickly that people have shorter attention spans, that they have a lot on their plates, legislators, the public, reporters, and that I had to learn to distill that down, even though there is a ton of evidence and research about syringe access, and supporting the efficacy of syringe access. And so we learned along the way, and one of the things we did, we created the Campaign for a Healthier New Jersey, which supported our syringe access bills. And, one of the most successful pieces of that campaign was focusing on individuals. And this was one of the individuals who worked with us. Carol was a nurse in Atlantic City. She's now retired, and she had lost her son to injection-related HIV. And she became one of our best spokespeople, and as you'll see when I go through some of our media clips, became part of the story because it was what propelled us forward in New Jersey. Wasn't statistics, it wasn't facts, it was one part of our campaign, but it was really this story that was ultimately about what would you do if this was your child, what would you do if this was your parent, if this was your loved one. Another person who was part of our campaign, Michelle, who at that time was working for Planned Parenthood and had lost her father to injection-related HIV. And, you know, again, you know, hitting the point of how little facts and statistics can get you, you know, the opposition's most frequently used talking point was just that syringe access sends the wrong message. And you can't really counter that with facts and statistics. And so we countered it by having a campaign that talked about everyone's life having value and everyone's life being worth protecting. And we had a whole array of different people from different walks of life, a diverse group, who were willing to say that message. Because, you know, another key thing when you're messaging about these issues is in order to get your foot in the door, it's really important to have spokespeople that other people can relate to. So you want to have a diverse group of people. It's not just, you know, about me getting up there and, you know, talking about all the articles that I've read about syringe access or talking about, you know, things I've seen. It's about people that a whole broad range of people can identify with. And so we really did that with this campaign, and eventually it became something that really overcame some really, really strong opposition, because New Jersey was very unique in that most of the states around us were allowing some form of syringe access, and eventually by the time we got the bill passed, you know, syringe access had spread across the country, and it was really a blind spot that this state had that I still to this day can't totally figure out, but it was there and was a real challenge, and we needed to change a lot of minds on this. And so in terms of making this a story, I want to go through a few clips, media clips that we had that show how the story built and how it gained support. And part of the story was Senator Nia Gill, and this is a picture of Senator Gill, and this is a sort of a mini white paper that she actually gave out. We wrote it, but she sent it out to her constituents, and you can see how she frames the story. She frames it as protecting for her women and children and families in her community. And at that time, probably the staunchest opponent of syringe access in New Jersey was an African-American male senator from Newark, who for a long time was able to hold this up. And, you know, we really needed someone who also represented that community to speak in favor of this, and Senator Gill was just fantastic, and, you know, at the end of the day ended up holding up judicial nominations and legislation and all sorts of things as part of this long battle to say, you know, we're not going to do business as usual until this bill passes, and she was the right person, the right spokesperson to do this. And this is an editorial that she wrote for the New York Times. And again, I love the little hearts in the middle. She wasn't at all afraid to pull on people's heartstrings and to talk about this as an issue of caring for our loved ones and our family and our friends, which was very much how the opposition didn't want it framed. And this was, again, really, really successful. And this is a little difficult to see, but this is the front page of the Press of Atlantic City, and at the bottom of the page there is a picture of Carol, who was the woman I showed her testimonial earlier, with a picture of her son. And again, her story became this story and part of, you know, this ongoing battle that everyone could relate to this. What would you do if this was your child? Would you, knowing as she did that her son was injecting drugs, and knowing as she did that, you know, the risk he was taking and running and how horrible it was that he didn't have ready access to clean needles, what would you do in this position? And we also took Carol to a lot of legislative visits. She testified before the legislature and really in a very real way managed to present a very compelling story. This is another New York Times article talking about the fact that at that point the legislature was not amenable to our legislation. But again, and the article presented a lot of people who were actively injecting drugs, still using drugs around the state, and I think the reporter went to Atlantic City for this one. And, I always say to people, don't be afraid of the media. It's good to have some media training. It's good to develop a message and stay on message. But if you do that, you can expect good results. I mean, we've been doing this for 11 years now, and I don't know that we ever had a bad news article about syringe access. All the individuals in this article were presented with great dignity and with great compassion, and they talked about their need for sterile syringes and how hard it was to get them. So it's another example of having a good story, but also being prepared and knowing how to message about your issue. Another part of this story was at some point when our legislation had failed several times in the legislature, I went to two cities, Atlantic City and Camden, to get them to pass ordinances and basically defy the state and say, we're going to do syringe access. People in our cities are getting HIV, people in our cities are dying, and you won't do anything, so we will. And again, having a great spokesperson, this is Ron Cash, who is the health officer for Atlantic County and the director of the health department in Atlantic City, and he became, again, the face of this issue. Here was a health officer in a city where I believe it was 1 in 33 African Americans are living with HIV. He was someone who was from the community fighting to save people's lives and having the state tell him no. And this is an editorial, an act of defiance, because, it became a huge story that people could relate to, that these two cities were trying to get syringe access and wanting to set up syringe access programs in the state not letting them. Because let me just say, once the ordinances were passed, the state did promptly sue the cities to stop them, which took the whole issue to just a level of absolute ridiculousness in most people's minds. At that point, the president of the Senate actually made a statement, and we knew we were hitting critical mass because he said it's really hard to say no when these cities want it that bad. These are some advocates at a city council meeting in Atlantic City the day they passed their ordinance, which was right before they got sued. Again, the story of how these cities were doing this in spite of everything the state was saying. Some really positive editorials. Again, a story about how this battle is shaping up. And again, someone who was injecting drugs speaking to the press and talking about the need for syringes. And the fact that the two cities were in a fight together was a big part of the story. At one point, we actually had a former Miss America whose family lived in New Jersey, although she had been Miss Illinois. She came to the legislature to testify, and again, it was something people did not expect, and I will say I cold called her. I will cold call anybody at any time for anything, and have been pretty successful at it. And so, again, it was some unique press coverage and something that people weren't expecting. When we got Republicans on board, this became a headline. The fact that there was bipartisan support, again, I know Robert's going to talk a lot more about having the importance of bipartisan support, but it really was key. And then, a little about creating coalitions. Part of our campaign and also part of the story was that you had this is just a partial list of groups who supported this bill. And they went from grass tops groups like the Medical Society of New Jersey and the nurses down to local groups, some of whom were the ones who eventually implemented syringe access programs in New Jersey. Having the pharmacy groups and social workers on board, and having these folks reaching out to legislators and to local council people was really key. We had faith leaders who were involved. We had the head of the Black Ministers Council in New Jersey who testified on numerous occasions in support of the bill. And at the end of the day, we just reached, truly a point of critical mass and a point where people were, the story just carried the bill over the finish line. And so, a couple things I'll say, about messaging and about working with groups is, again, when you're presenting things these days, and now that we've learned a lot, we usually will have an information packet for legislators, and it will have just one-pagers. We don't, it's, again, not a dissertation, as I learned. You want to have all your ducks in a row in terms of actually having your research if somebody wants it. But a lot of times for legislators, the sheet that's in front of you is really the key thing. It's the first thing a legislator is going to say is who's going to support me and who's going to slam me. And so we always have very visible at the top of our information packet the list of groups and individuals who are supporting this. Again, we message, around and stay on message in terms of it being about saving lives, about public health, about families and communities, and don't get off message no matter what people say, and having these groups really helps you do that. I think I am out of time, and then I think I've basically covered everything, and I know there's going to be some time for questions, so I think I'll leave it at that.
Great. Thank you so much, Roseanne. So I'm going to do a little bit of changing of the presenter over on my end. So next up is Robert Childs from North Carolina. So hold on 1 second. All right, Robert, you are on. Oh, wait, except, Robert, I need to change the presentation to actually yours. That would probably be helpful. Hold on 1 second here. I imagine Robert wants to see his own presentation.
Oh, that's nice.
There you go, Robert. Now you can go through your own slides.
Excellent. Well, thanks, everybody, for having me here today. I really appreciate it. And I'm going to echo a lot of what Roseanne said in the previous presentation and cover a couple other items as well. So some of the things I'll be chatting about today is just a little bit on CHRC, some of our conservative and law enforcement-led harm reduction legislation, then talk about some of the key advocacy methods that we used in order to push our bill and also try and get it passed and get it through the legislative process. So a little bit about us is we're just a comprehensive harm reduction group located in North Carolina. We work on all the standard harm reduction issues and also do a lot on advocacy and resource development and coalition building. And one of the things that makes us a bit different than some of the other national harm reduction groups is we do focus a lot on harm reduction for law enforcement and veterans, as well as drug users and sex workers. And in North Carolina, we're based all around the state. We have employees in kind of each of the corners. We have one in Appalachia, one over in Fayetteville, one in the Capitol, and then we have drug user unions in Greensboro, which is kind of in the middle of the state, and Hendersonville, which is a little south of Asheville in Appalachia. And we're not a big agency. We only actually have 2 full-time staff and 1 3/4-er, and we have several key consultants and a lot of really strong volunteers and action team members. One of our key things that helped us be a successful advocacy organization is we do have a lot of action team members who actually take action through a variety of means, which I'll talk about later. And from our paid staff, we're a third law enforcement and veterans, and a third directly impacted people, and a third public health 30 people who are all pushing for these harm reduction advocacy issues. So with our legislature, we have a bit of a different legislature than my northern friends. And in the previous legislative cycle, which is 2011 and 2012, we had a Republican House and Senate and a Democratic governor. And then in the new cycle, which is 2013 and 2014, we had a pure Republican supermajority. And in the past couple of years, we've had some Democrat-introduced legislation, which were 2 full syringe decriminalization bills, and both of these failed pretty much just because the sponsors were Democrats. So in 2013, we went at a different angle, and we went for two harm reduction bills that we successfully advocated for and passed that were Republican-based, and one was a comprehensive Good Samaritan bill and also had an alcohol immunity and a naloxone access portion, and we also had a partial syringe decrim bill, which was extremely law enforcement-based, and that one was called Possession of Needles Tell an Officer, which means if you inform a law enforcement officer that you have syringes or broken crack pipes on you for anything sharps like cookers, that you can't be incarcerated if you inform the officer that you in fact have those on you. So the way that we got these passed is through a variety of different methods that have proved really successful for us. And the first thing we did was, instead of looking at new ideas, which look at an old idea. And that old idea, which was our initial part of our battle plan, was kind of looking at the art of war. And I know, some people may have heard this by some too, but it basically talked about how to create a battle plan to win battles, but you can take a lot of those battles and apply it to an advocacy campaign. And one of our key folks who were traditionally not supportive for us were law enforcement. And what we did was went after law enforcement really hardcore, and what we tried to do is take them from our biggest critic and convert them to our biggest advocate. And in North Carolina, whenever we were trying to pass these syringe bills, almost everybody would ask what the sheriffs think, what does the police chiefs association think. And traditionally, they weren't supportive of our syringe bills, but what we did is we made them invested in it through basically taking the word on the street for different law enforcement departments in the state. And we actually got over 80 involved in our advocacy and also got key endorsements from former members of law enforcement who are serving in the legislature. And we also got the Sheriff's Association on board after we completed a lot of advocacy. And we also focused a lot on conservatives, and we knew if we were going to pass anything in the North Carolina legislature, it had to be representing the heart of the Conservative Party and also get them extremely invested in it. And we knew if we could get several of the key Republicans interested, we would be able, to move this bill really fast since they were the party in power in all portions of government. So the other thing that really was a tough thing for us initially is there was no media coverage of these harm reduction issues. It was very few and far in between. So we set up a media team of a lot of volunteers and one of our staff members to really go after getting the media to cover our issues statewide. And one of the key things I did, which was really helpful, was I cataloged all the reporters who had ever done a story on overdose or syringe access, and kind of created a spreadsheet and worked to create relationships with them. And then after I'd formed relationships with them, I would just be sending them stories, sending them information, helping them out with other stories that they were asking for assistance with, and got them over time more invested in the issues to start covering it. And we also worked on getting them to cover these issues on a more regular pattern. And also, we wanted them to view us as a resource they couldn't live without. And eventually we got to the point where that was definitely the case. And the other thing, kind of Roseanne touched on this too, is like creating key fact sheets and resources for them, as well as the legislative members that, really hit the point of what we were trying to push with our messaging. And since we were focusing on conservative values, law enforcement health, almost every single piece of material that we created definitely did that. The other thing that we did in keeping our base involved with the media work is we would have them start in our volunteer program. Then we would start giving them regular harm reduction and advocacy information. And some of you on this call I know are members of ours. And we talk to them about how to get involved through our email list. And then we would advocate that they take action and do a lot of follow-ups to get them to do that. So we had a lot of people write op-eds, help us with legislative visits and phone calls. Our organization personally prefers phone calls and legislative visits over have people sending emails. We just find that we get more response that way. And then we also did a lot of different article writing over the legislative period. And we had a lot of success doing that. We had over 360 media mentions and articles in 2012, and this year on pace for over 400. And not only were we able to get in all the conservative and liberal papers in North Carolina, but also some of the national media that gave us really good coverage of our issues. And here's just like some pictures of some of the places we got into. But our most proud was getting into Carolina Journal, and those of you north of the Sweet Tea line may not know much about it, but it's one of our leading sources of conservative media. And they came out in great support of our issues and were really big allies when we started really advocating for these issues at the legislature. And also, talking about Roseanne, brought this up earlier, it's like the messenger is often really, really important. And so we had Miss New Hampshire, we had Miss North Carolina. Miss New Hampshire went to public health school with me and helped us out down here. And we also had Miss North Carolina, who also helped out with the advocacy, and the legislators loved that. And we also had lots of policy experts. We had law enforcement and faith leader and veterans and directly impacted mothers specifically to help us do a lot of advocacy at the legislature, and that really, really helped with when they saw these people come to the door, like a veteran and the veteran officer to law enforcement officers. You know, they instantly become very invested in those things because they really care about those issues. So having somebody that they really cared about show up at the door really made a difference. And then we also used a lot of very specific language that they really like. Like when we were talking about needle stick prevention and overdose prevention, we were talking about being pro-life and being pro-law enforcement safety. And using those key terms really was helpful when we were doing advocacy. And then we also made a very concerted effort to present at the conservative think tank to kind of talk to all the leading conservative leaders about why we're invested in these issues and to get them really excited about this legislation, which is repealing some of the nuances of government that have unintended public health and public cost consequences. Another really key thing that we found to be really important is just to be consistent with your language, with your fact sheets, and also being present at really important meetings, and also to like advocate like mad through each of the processes, because you know, whether the bill's in committee or having a general hearing or a House vote, it's really important to be there and let people know that this is a really important issue with people that they care about through every single step of the way. We also found that occasionally you need to rebrand an issue. So I'm a public health guy, and initially, you know, we billed this as a public health issue, but that went nowhere legislatively. And so what we did is we rebranded the issue into a law enforcement health initiative for the syringe bill specifically. And what we found to be most helpful is a lot of active officers wouldn't come out publicly for the bill because they didn't want to take a side one way or the other, but we could survey them anonymously. So we went and did roll calls and crisis intervention team trainings and got them to take anonymous surveys. And what we found is that there's a significant amount of people who had a needle stick injury in their first 10 years of service, a significant amount of people who had a crack pipe or meth pipe injury in their first several years of service. We found that 84% of them supported flat-out syringe decriminalization when we asked them anonymously. But if we would ask people in a group, what we would find is only the people with the strongest opinions would really talk, and it would make people think that that was the predominant opinion, where, in fact, it's completely different. Most law enforcement officers, the key thing for them is to come home safe at the end of the day. And if they don't come home safe at the end of the day, they can't do their job. So what we were really doing was, you know, how can we make your work as safe as possible so you can keep doing what you're doing? And they said the syringe decriminalization and crack pipe puncture wound, you know, issues are really important for them. And we also talked a lot about syringe availability in the community, and all we really had to do was show this beautiful image. And when we showed this beautiful image, people got, you know, that I don't want to be stuck by something that's being used multiple times. So a lot of them have come come along purely from this image, showing I normally start my presentation and ask them, what syringe would you like to be stuck by? And, of course, everybody wants to choose the one on the left, which is one which has never been used before, or the one-use one over the one that's being used 6 times. I mean, in Carolina, from surveying a lot of our injectors, the people are using the syringes an average between 20 to 50 times. These syringes don't accurately portray what is actually out there and what officers are actually getting stuck by, which also led to a lot of support for this issue. So one of the things we find really important throughout the entire process is to keep your base involved. We have a really huge amount of people on our action team, and so, we've found that we want them to be involved and take action at a really high rate in order for us to have success on the legislative level. So we kept in a lot of contact with them through emails and phone calls, and then we would provide them lots of opportunities for action, a lot of opportunities to call the legislator, a lot of op-eds, and also participate in strategy sessions and actions, and they found that really nice. And the one thing, we're really a big fan of is just measuring where you're at throughout the entire process. There's a great set of resources called the Boulder Advocacy resources, and if you just Google it, it gives you a really good, it lays out how to measure how you're doing in advocacy, because a lot of people think if I can't get a bill introduced or if I can't pass a bill that I'm not being successful, when that's not true at all. It's, really, you've got to make sure that, you're working in steps, and, if you're heading in the right direction, that's a really good thing, and this thing really helps lay that out for you. And also, it's really good to check in with your team and your action team and the people that you're working with to improve their health all throughout the process, to make sure that, where you're going is the right place, and to make sure that, things are going to head in a positive direction for your work. One of the last key points that I do want to say is when you're doing your advocacy, just to make sure that you keep neutral storytelling, that doesn't favor one political party or the other. And, you should have a conservative and a liberal mother-in-law or father-in-law that you can talk to and see if your, story and your advocacy message is getting across in a way that's neutral and, it doesn't string, one party line or the other. It's really important to, make sure that you come across as a bipartisan issue. And especially, oftentimes in harm reduction we ignore our conservative brothers and sisters, but they're really important to involve in this process and get them on board in order to pass legislation, especially south of the sweet tea line where we can't pass legislation without conservative involvement. So some of my takeaways for this session is just to make sure that you have a battle plan and adjust it as necessary, but, really, have something laid out and go for it. And don't be afraid to rebrand yourself, because oftentimes, we used to use the term syringe exchange a lot, and we've gone away from it because we found that it's politically not advantageous. And even Democrats in our state won't be associated with syringe exchange. But they'll support syringe decriminalization. They support biohazard selection. They support each component, but they don't support the word syringe exchange, which brings it all together. Right? We also found that it's really important to work with conservatives and law enforcement, especially in the South, and use them to do advocacy. And also to use the neutral language to meet with potential allies and venues that they feel comfortable at. Really work really, really hard to build common ground and focus on that common ground when you're doing advocacy, and to work hard throughout the entire process and to work smart. You don't necessarily, it helps to do it in a lot of hours, but, you can work smart as well and work efficiently and streamline systems. So, you're putting a lot of effort in for the right spots and the right reasons. But with that, I thank everybody for their time and listening today, and I'll take questions after Matt's presentation if you have.
Great. Thank you so much, Robert. So I'm going to switch over the slides here, and while I'm doing that, I'd like to encourage people and remind folks that if you want to submit a question, there is a chat function over on the right side of your screen. You'll probably see a list of people who are attending the conference. and next to that should be a little hand icon, and next to that tab is a little dialogue air balloon, a cartoon, dialogue balloon. So if you click on that tab, you can submit questions to us, and we will be going through those. And then once Matt is done, because Matt is up next, we will be going through those questions and hoping to get through as many of those as we can. So Matt, I am turning control over to you. So hit it, Matt. You're on next.
Okay, great. Thanks very much. Can you hear me okay?
Yep. Thank you.
Okay, great. So thanks for having me. I'm especially happy to be on this call with two people representing a couple organizations in North Carolina, Harm Reduction Coalition and DPA, that I'm huge fans of and that are really doing great work. I seem to have just lost control of the slides. Hello?
Yep, Matt, go ahead. You can. Oh, did I not make you presenter, Matt? I thought I did.
I was for a second, and then it all went away.
All right, I'm going to try it again here.
There we go.
All right, there you go. You got it again? All right, there you go.
Yep.
Good job.
Okay, thanks very much. So I'm going to talk a little, as I was introduced, I'm from an organization called Vocal New York. I'm going to give a little bit of background on who we are and what we're about and how we go about organizing around our issues. Talk a little bit about our kind of methodology, and then get into a few examples of actual campaigns that have been successful in the recent past. So first of all, Vocal was originally founded just shy of 15 years ago, and at that time it was an organization called the New York City AIDS Housing Network. It was founded by Jen Flynn, who some of you may know as the current managing director at HealthGap, and Jose Capistani and Joe Bostic, two men living with HIV with a history of injection drug use. And, the network was originally set up specifically to focus on expanding housing rights and the quality of housing and related care for New Yorkers living with HIV. After this, with the work that went into it, New York became one of the few places in the United States with a right to housing for HIV-positive people. Over time, NYCAN continued to develop, continued to take on a broader array of issues, including stuff around harm reduction and drug policy, policing, and a number of other things, and eventually, kind of wound up rebranding, which I'll get into in a minute, to reflect our expanded mandate. So today, we're mainly New York City based. We're a membership organization, so we have a pretty small staff, relatively speaking. It's kind of about 15 people, and a very large membership. And really our bread and butter day to day is community organizing, outreach, and community mobilization. We do have other chapters that are formally organized in Westchester County, north of New York, and in Albany, our state capital, and then members spread around in other places. We know that about 6,000 people participated in at least one of our events last year. And kind of more, typically we can turn out, in the hundreds or even more for kind of bigger events. Right now we have 5 community organizing projects. The first, which I'm going to spend most of the talk speaking about, is the New York Users Union, which really is sort of our home for doing work around harm reduction, advocacy, and drug policy reform. We have an HIV/AIDS community organizing program that continues a lot of the work of NYCAN, continues to run an AIDS housing network, as well as some other stuff. We have a civil rights organizing program that is mostly focused on police reform and police accountability. So if any of you heard the news over the past couple months of the Community Safety Act legislation that was passed in New York, which Mayor Bloomberg vetoed and was subsequently overridden, that's an effort we were hugely involved in. We also do a lot of work around what we call economy and democracy, where we try to tie in, the sort of narrower issues that we're focusing on with a broader history and array of interests around economic justice, access to the tools of democracy and participation. And finally, we have a thing called the GROW project, or the Grassroots Organizing to Win, which is really kind of cuts across all these other things and is a kind of member-to-member base building effort that's kind of ongoing at all times. So the Users Union, the goal of the Users Union is to build power for low-income people who use drugs in order to promote health and human rights in our community. And we see power building in the kind of classic community organizing sense where, it's the authority and the ability to move policy or, resources around our issues. The Users Union, the New York Users Union, as Vocal, originally wasn't part of NICAN or what today is Vocal. It formed maybe when Robert was still there at a Positive Health Project as a kind of small group of people with a kind of history of drug user-led activism in New York coming together to do some work around hepatitis C prevention, care, and treatment. That group eventually moved over to NICAN as a kind of umbrella. And, because of some of that stuff I was talking about before and the changes that have been happening in NICAN, eventually those two, the Vocal, the Users Union, and NICAN merged and became one organization. And the way the Users Union works, because of the kind of, the community organizing and base building we do, we have a pretty large membership. The way we make decisions about, what to undertake, our strategy, what campaigns we're going to focus on is generally, there's a few different ways we do it through meetings, but we have a leadership committee for all of those organizing campaigns that I talked about before. They're open, so no one's elected to them. Basically, you kind of become a member by participating, kind of in the old ACT UP style. Okay, so, just a little bit more about where we're coming from with all of this. We are very focused on, as an overarching goal of ending the war on drugs, but we see this as part of a broader historical piece of racial and economic oppression in the United States. And our kind of chosen means of going about that is direct action organizing led by people directly affected by these issues. Although there are a number of other organizations working on this stuff in New York State or nationally, and we literally do nothing that isn't in coalition with other groups, we really see our strength and our kind of unique place as really focusing on that grassroots up, community level power building. More broadly, we see it as being, very much in the traditions of labor and civil rights and LGBTQ organizing. Because of that, we often work with groups that are outside the kind of, immediate sphere of harm reduction or drug policy. So we routinely work with, economic justice groups, migrant rights groups, that kind of thing. How do we get this kind of stuff done? So, our organizing work, for if anyone's ever read the Midwest Academy organizing manual or old Saul Alinsky books or something like that, read about, civil rights organizing in the 50s and 60s, it's really a quite similar methodology. We're lucky in a way here in New York because the kinds of folks we're trying to organize, we have a very relatively dense array of services for people who use drugs or with a history of using drugs. So we are, able to find people relatively easily by targeting syringe exchange programs, methadone programs, housing providers, the shelter system, and so on. Although we have community organizers on staff, much of our outreach is done really member to member. Whenever we make contact with a new person, we always will contact them again within 24 hours. We'll invite them to something. We put their information in a database that tracks their participation, the campaigns that they're interested in, and it lets us be much more targeted in who we're, calling for to do, get involved in a particular event or something like that. And, you know, the overarching goal to cement those kinds of relationships is to get people to move to action as quickly as possible. You know, we don't provide incentives or anything like that other than, you know, we provide food and transportation for most of our events because we are, you know, working with people that really can't otherwise afford it. But, you know, otherwise it's entirely built on self-interest. And so, you know, we're looking for anyone who's interested to give them work to do that's meaningful to get them engaged, you know, in something beyond just conversation as quickly as possible. I've talked about this already. And, you know, the kind of leadership development process, a lot of what we do, because there's frankly just so many people involves learning by doing. And that can be coming with us, it can be participating in, you know, the leadership meetings, it can be doing phone banking to outreach, it can be, you know, going and helping run events at different places. It can be coming with us to meet officials or electeds and so on. There's kind of a wide array of stuff that can be done there. We do a lot of training as well. A lot of that is kind of popular education methodology, and in particular we have this thing that we call the Power Academy, which initially started as you know, a real top-to-bottom 3-day community organizing and power building training, that's also now added on a number of issue-based trainings as well that we do periodically. These are some of the, you know, there's a lot of different issues that the Users Union has focused on. You know, it does tend to be stuff that will fall into the scope of what you'd expect in harm reduction or drug policy. When we're going about prioritizing, you know, there's a sort of endless series of things we could be working on, but when we're making decisions, some things we try to take into consideration is, one, that the issue that we're going to focus on has a real chance of resulting in a concrete improvement in the lives of people who use drugs, that the means of getting there creates ways for people in the community to build a sense of our own power and actually build real power, and that victories can do things that alter the relationship of power and let us get more done later. That it be something that's both winnable but connected to these bigger long-term ideas around ending the war on drugs and improving racial and economic justice, and that among our membership that it's widely felt, so a lot of people, you know, a majority agrees, or there's consensus that it's a good idea, and that people are really motivated to get on it. So just a couple quick examples in my little bit of time left about some actual campaigns we've run. This is one of the first things that the Users Union worked on when it came over to what, you know, to NICAN and what is now Vocal, which was what ultimately became legislation to expand syringe access in New York State. So I won't read all of this, but, you know, the kind of issue behind it was that we had a situation where although syringe exchange had been legal since 1992, people were continuing to be arrested for criminal possession of a hypodermic instrument, which is in the penal code in New York. People were being in particular arrested and charged with drug possession because of residue left in syringes. And so one of the first steps that the Users Union took was to actually document this. So they did a big, you know, community-led research project that resulted in this report, wound up getting, you know, a pretty good amount of attention and being a springboard for us getting legislation introduced to actually reform this. And subsequently, that legislation was passed in 2010. And this, you know, what this did was add kind of an additional carve-out in the penal code and public health law here that says now that if there's residue in a syringe, you can't be charged for that reason. Another example that I like to give, because it kind of shows two sides of how we work, is a campaign that started last year around HASA, which is the HIV/AIDS Services Administration in New York, which, among other things, provides housing support for permanently disabled people living with HIV. This is part of our welfare system, and the commissioner, Richard Dorr, who's pictured there being yelled at by one of our board members, came out and said at the beginning of 2012 that he was going to get tough and crack down on drug use in the HASA system because there were just too many people using drugs, and this needed to be cut off. People needed to be, dealt with harshly and lose their benefits if they were doing this while getting HASA benefits. So we do a lot of direct action work, and Vocal got a crew together, went to his house in Brooklyn Heights at about 6 o'clock in the morning, woke him up, and then escorted him to work. For some reason, he decided to take the subway downtown, and so had about 40 Vocal members following him from his front door all the way to work, chanting, making a huge amount of noise, generally making him uncomfortable. We also got the city council to do hearings on this subject, and because of tactics like this, because of a couple other actions, it just got a huge amount of attention, and the city, pretty quickly backed off of the policy. Now, the other side of this is that, although we get a lot of attention for the public actions and stuff like this that tends to be a little more dramatic or angry looking or something like that, we don't do anything without coming in with a concrete proposal for some kind of positive solution. So we saw this as an opportunity to kind of, try to push back and say, not only is that policy not working, but, just the way that HASA deals with, people's drug use in their system in general isn't working. So, one other problem that was identified is that, when CASACs were identifying HASA clients with a substance use issue, they would just get referred to abstinence-based drug treatment. They wound up, as of last year, having a 17% kind of completion rate, so the number of people that actually even showed up for one appointment. And it's just not something that a lot of people wanted some other way of dealing with that. So we were able to go back to them and work with a number of other harm reduction groups, actually help design a program or a new policy that went into effect July 1st this year that actually provides that harm reduction services can be a primary referral option. And it's up to the HASA client to determine whether or not they, want one thing, one modality or another. And actually that there's no stick. There's no, kind of downside. It's just purely a way of making more options for people, assuming that some people are going to want to take something up and make some kind of positive change. Last thing I'll talk about really quickly, this is something I've spent a huge amount of time working on this year. We just got a first in the country hepatitis C testing bill passed. What it will do once Governor Cuomo signs it any day now is require, along the lines of the CDC recommendations, that inpatient hospital settings and general practitioners offer a hep C test to anyone born between 1945 and 1965. It also provides for some linkage to care stuff in there and requires that the state health department evaluate the impact of this. It's modeled on HIV testing law that was passed in 2010 and which was evaluated later and hugely expanded the number of people getting tested in New York. Now, why would we necessarily focus on this? It's not specifically about people who use drugs, although that age cohort certainly overlaps a lot with our membership. I'm going to just jump to the end here. It really, for us, when we started talking about this with the Users Union leadership and with our membership, Hep C is something we have been focusing a lot of attention on. It's, today, because of the success of syringe exchange around HIV at least, Hep C is kind of a much bigger immediate issue for people in our communities than HIV. And we felt we needed to do something that was going to really increase attention on the epidemic. So few resources get put toward Hep C here compared to HIV. And, it's also something that, we saw an opportunity here where we thought we could really expand the constituency around this. So, we think there's a large number of people in New York, as there are in other states, that, were infected through hospital-based infections and stuff like that before there was blood screening, or that, had used injected drugs decades ago and became infected and don't know it. So this was really a way to, push this in a way that we thought we could build a much bigger base to focus on the issue and ultimately be able to tack back and, get some of the other stuff we want done on hepatitis around, access to other kinds of injection paraphernalia and improving prevention, better access to care and treatment and so on. And ultimately, we were very lucky that one of the bill sponsors in our assembly, his father, who was also a legislator, actually died from complications of Hep C. We wound up being able to build a very large coalition. We got the AARP involved in this. And, all this together really helped us push it through to the point where between both houses of our legislature, we only had one vote against the bill. So, this is something we hope we're going to be able to translate into, energy to really focus back on care and treatment for people who use drugs living with Hep C, and that's the next thing we'll be doing with it. So I'm kind of running out of time, and that's the end of the presentation anyway, so I will leave it there.
Great. Thank you so much, Matt. So we've got a good chunk of time for questions and answers, so folks go ahead and keep submitting them via the chat function on the call, and we'll start going through them. The first one I have, Robert, is for you. Can you clarify what you said earlier about changing your campaign from syringe exchange and syringe access to something else? Can you talk through that briefly again, please?
Sure. So in North Carolina, if you say the term syringe exchange to 80% of the Democrats or 100% of the Republicans, they instantly will not want to have a conversation with you. So instantly that kind of takes away your ability to communicate about it. But if you talk to Democrats and Republicans about, do you think syringes should be decriminalized to decrease bloodborne disease and improve law enforcement safety, you'll get huge amounts of support for that. Do you think that there should be biohazard collection for people who use drugs, diabetics, Fusion injectors, or anybody who uses any injection device? You'll find almost complete support. So if you're talking about each one of the components, people have no problem about it, but the word syringe exchange is bad in North Carolina, so we don't use it. And we also don't think syringe exchange is the pure solution to the syringe problem in North Carolina. We view syringe criminalization as one of the largest issues for our state. And so what we're really aiming at is decriminalizing syringes entirely. And I used to run a syringe exchange program in Midtown, New York. And the big problem we were having when I was there, but they since changed the law, was a lot of people were being arrested just for bringing their needles back, or they were being arrested for the syringe possession and the cards would go missing. But if we decriminalize syringes entirely, this will get rid of a lot of that negative stuff that can occur if there's just a syringe exchange exemption. So I'm really pro in using language that, allows you to have a conversation with somebody and break bread. And there's a lot of hostility towards certain words south of the Mason-Dixon line. So we're just extremely careful with our wording, and we make sure to be consistent with our messaging so we can keep building bridges in our state.
So the next question is for all three of you. For all three of you, you focus on HIV and hepatitis advocacy. And in the HIV community, there's been a long history of advocacy that was rooted initially in the MSM community and, of course, has moved a lot far beyond now. And so for all three of you, can you talk a little bit about your partners in your HCV advocacy, sort of where that's come, and what other local folks might find for natural partners around HCV advocacy? Let's go in order. Let's, Roseanne?
Sure. Yeah, it was very interesting in Jersey because, we started this so long ago. I mean, it was 11 years ago when we kicked off the campaign that HCV was not, I think at that point was just beginning to get traction. And we always incorporated it into all our materials, into all our verbal communications that this was about HIV and hepatitis C. We did not at the time have in New Jersey a lot of hepatitis C groups. They were very small. They're very scattered. I mean, we're a very suburban and rural state. I mean, it's kind of interesting. And so we actually got different hepatitis C groups on board, and they had developed over the years for our pharmacy sale, over-the-counter bill, but they were not actually as involved for syringe access just because they didn't exist. But we talked about this constantly. It was certainly an issue for a lot of the groups we worked with, medical groups, social work groups, and it also would resonate. Like I say, we always made very certain to say it and write it, everywhere that we were talking about both of these and any other bloodborne diseases. And it resonated with different people who had experience with hepatitis C. We had the city council president in Atlantic City who sponsored our ordinance for syringe access, actually had quite a few constituents talk to him and come to him with issues around hepatitis C, and that was a big thing for him, and he always talked about hepatitis C very prominently, probably more prominently than HIV. So it was something that changed over the years, but even from the beginning, resonated with particular communities. And we had a gentleman who was one of our spokespeople who had contracted hepatitis C from when he had been using back in the day. At this point, he was abstinent, and he was one of our spokespeople. So we definitely did try and incorporate that, and it grew over time.
Great, thanks. Again, in order, Robert?
Yeah, in North Carolina, there's extremely few hepatitis resources and education about it. We're actually the state's largest hepatitis educator, and that's really sad to me because I really feel like our state should be more invested in it, especially because most experts predict that 1 in 12 people in Carolina have hepatitis B or C. And there's a lot of risk in our state, and they don't really track it too well, and there's barely any advocacy for it. I used to run the state Hep C task force in Carolina, and there's really, very few people and resources involved. We do have 2 of the leading research think tanks on hepatitis in North Carolina, which did help a little out at UNC Chapel Hill and Duke, and 2 really great doctors who lead programs, but they're limited in what they can do legislatively. And so we found with advocacy that was related most to getting some legislation passed for the syringe issues, that the community most invested in doing advocacy for were the law enforcement officers, because they, in our state, about 1 out of 10 is going to get a needle stick or a crack pipe puncture wound in their first 10 years of service where they're getting exposed to Hep B and to viral hepatitis C. So especially a lot of the commanding officers were really key in assisting us with giving us connections and also, really telling us to go out and support these initiatives because it was protecting law enforcement officer health, and that really rung heavily with legislators in the legislature. And our bill sponsor for our syringe bill was a former officer. And he was just like, this stuff happens, this stuff is real, we need to do something about it. And that was really huge in our legislation.
Great. And Matt, thanks Robert and Roseanne. And Matt, you talked a little bit about education and awareness in terms of HCV and your desire to sort of mobilize around it. But can you talk a little bit about who your sort of natural advocates are and allies are in HCV work in New York?
Yeah, and I mean, we do have a relatively large group of providers and other resources here in New York, so it's a little different than, what others were just describing. But even so, it's a relatively small field. I guess, first of all, as far as groups we hadn't really worked with much before and, which others could, AARP really wound up being incredibly helpful. They didn't get involved in the legislative campaign until the very end, but they were fantastic. And, that wasn't about, positioning themselves around something to do with harm reduction. That was really directly related to, the fact that, what we know from the epidemiology is that roughly 75% of people with chronic hep C in the country are in that baby boomer generation. And, that the CDC and now recently the U.S. Preventive Services Task Force are both recommending that people in that age group get tested. So, it was something that did affect their constituency, and it was, something that we were able to use to get them on board with it. And that's, definitely not a group that we normally have a relationship with, but they're obviously hugely powerful. And they're, they should be all over the place. So, I mean, if you are trying to do hep C work, in whatever state you're based in, I think it's totally worthwhile reaching out to, they have either state level or regional policy directors all over the country. You can sort of cite their involvement in New York and as a way of getting them engaged maybe. They put out press releases about it and so on. So that was especially helpful. For Vocal, our bottom line is really directly affected people, and it's people who use drugs, and it's, not what other people are bringing. I mean, and when I say us, I'm also really speaking about the whole harm reduction community that we're organizing out of. So there were, a number of really incredible harm reduction agencies in New York that got super involved in this, NIRI in the Bronx, Citywide in the Bronx, some other folks. Harm Reduction Coalition in particular was, really all over this and a really key partner on a lot of the, grunt work of legislative outreach and all of that. And our role, oftentimes, although this was not a particularly contentious campaign, but, one thing we try to do is raise the tension level around policies sometimes, because it's just something we're able to do in a different way than some other people are able to. It's also often useful for, we don't mind being the kind of cranky ones that people are a little annoyed with, and then other people can be the, reasonable people to help get the job done from another angle. We didn't have to do too much of that for this campaign, but in general around Hep C, I think, Hep C policy is in dire need of that kind of thing. One reason you have so much more resources for HIV is because that kind of tension raising has not been invested in.
Great. Thank you so much, Matt, and also to Robert and Roseanne. The next question is also to all three of you. As you have had your hard-won legislative victories, how have your campaigns evolved to get those folks most impacted informed about the new legislation, particularly in more disenfranchised communities? And let's go in the same order again, because that worked well before. So go for it, Roseanne.
Sure. I will say it's a lot of hard work in New Jersey. One of the things I really found interesting about this call is that everyone's working in such different models. New York City has such an activist history, and people able to get to each other just, by public transportation and things. New Jersey's very different, and so, to some extent we had to make a decision because we're a relatively small office. I mean, for the first 5 years of our existence, the office actually was me and a part-time office manager. And so I spent a lot of time on the road. I presented to a lot of community groups. I built relationships with organizations that were already serving the community that we wanted to reach with syringe access. Now, once we got syringe access, reaching out to that community has become easier. It's still a challenge in New Jersey just because of the way the state's set up. But, for instance, we recently got a Good Samaritan bill passed and an naloxone bill and over-the-counter syringes. And so we're doing a lot of work with the syringe access programs. We have posters and palm cards and have tried, to get the word out about those new laws. And then also really the people on the ground at the syringe access programs have been on the front lines in terms of getting people who could speak, whether it was at a city council meeting or more often to the media, about why they needed syringe access in their communities or naloxone or whatever the issue would be. It still does present a challenge because people can't get on a subway and go to a city council meeting often the way they can in New York City or some other places, but really we've been trying to outreach through some of the frontline groups in New Jersey.
Thank you. Go for it, Robert.
Hi. One of the things we've really been focusing on is the enforcement side of it. So we really worked really hard on getting police and sheriffs to understand the new laws. So we have been doing outreach. We've met with over 80 departments so far around North Carolina on all of the different ends of the state. And one of our really big difficulties is our state's basically an 8-hour drive across. So we have a lot of ground to cover for a small group. And so what we've been doing is we try and go to as many stations and train at the roll calls and at the, they have a thing called crisis intervention teams, which trains officers, and so we do trainings with them as well. We got our new laws incorporated into the law enforcement curriculums, so whenever a new law enforcement officer goes through the academies, they instantly will hear about our laws now, and then we put our laws in the new legal review for continuing education curriculum, so officers know about these laws and how to use them effectively. The other thing we've done is we have 2 user unions in North Carolina, so we've been spreading the word through those user unions. There's also, some people may not know, we actually have 7 underground syringe exchange programs in North Carolina that are unaffiliated with our organization, but we know who they all are, and we make sure that they have materials to go out and spread the information about these new laws. We also have a overdose program where we're talking to everybody who's at risk of overdose about these new laws. We also have a street outreach program, and we'll all spread the word through that. We've made little cards so people can just put them in their wallet. We also go to a lot of churches. A lot of life in North Carolina is church-based, so, we do a lot of education to ministers and try and get congregations invested in overdose prevention and syringe access. We've been doing a lot of work with them. We try and hit like the city and regional meetings when we can, but oftentimes we just focus on a couple areas just because we don't have the staffing capacity to go to all of them since our coverage area is the entire state. It's a bit difficult. We have been doing a lot of media work in getting them to cover the Good Samaritan issues and the syringe access issues, and that's been a huge help in order to cover all the state. We've been able to get into every major media outlet in North Carolina to do that. We've also used the methadone clinics quite a bit to pass out information on the new laws, the recovery houses, the leaders in the recovery movement, and also the drug treatment movement. And getting them to pass the information to all the people that they're working with. We've also worked with a lot of mother networks. We've worked with GRASP and a couple other mothers associations in getting them to put out the word. and also like just a huge variety of different community groups who are our partners. We have over 100 members in our coalition of different organizations, so we're trying to get them to put the word out everywhere as well. And we've done a couple more things, but I'll keep it to that right now.
Yeah, and I mean, our strategies in New York are pretty, roughly similar to the kinds of things that Robert was just talking about. Even though we can get on public transit and go across town, we still have, it's a huge city. We also are trying to work statewide and have a very large state. So, I mean, just going to Albany is a 3 or 4 hour drive, depending on the traffic, let alone getting anywhere else. And, just here, like we've got 100-some police precincts, each with its own little culture, a huge array of different kinds of providers. And so, getting the word out correctly and adequately can be a big challenge. One thing for us that we're kind of trying to figure out now is that I mentioned earlier in the talk about the syringe access bill that decriminalized drug residue in syringes. We've been looking at arrest statistics lately, and actually since that law has passed, there have been more arrests than there were before, mostly not occurring in New York City. Suffolk County on Long Island has been a big problem in this, but that obviously points to the problem with you really do have to spend a huge amount of energy just making sure that the legislation you help get passed is implemented correctly. And there's even with laws that are now 2, 3, 4 years on the books, there's still problems with that kind of thing. And I think partly that's something we ought to anticipate with anything we do, just because the subjects we work on, the people we work for are not the most popular, and just the kind of discrimination and stigma that's built into all these systems is going to continue to undermine the positive policy victories we can get. But I think Robert in particular laid out the sort of different kinds of strategies you can take to get at that.
Thank you very much. So we have 5 minutes left, which is probably just about enough time for one final question. And that question is, how do you see harm reduction and the Affordable Care Act working together? And let's go in reverse order this time just to mix things up. So Matt, you're still up.
Okay. I've actually been doing a lot of work on this. One thing the Affordable Care Act has done is kind of provoke this, redesign of Medicaid in many states. And in New York, that's meant that, for the first time, it's kind of created this opportunity to start thinking about potentially funding harm reduction services through Medicaid. That's got its positives and its negatives, and it's something we haven't completely figured out so far. But, I think, if you approach it in the right way and you get involved in the big changes that are happening, particularly with Medicaid or Medicare, at the moment there's a bunch of opportunities for linking in either ideas or funding or services around the kinds of things we want with, health homes and managed care organizations and things like that, really we just did not have previously.
Thanks, Matt. Robert.
Well, we here in Carolina making that thing's implementation is a bit difficult. I'm not sure yet, mostly due to our state's unwillingness to incorporate a lot of it. But yeah, it's here we've been very hesitant to implement them. Our health services are in dire straits because things are getting cut like crazy with our current budget. So to be honest, I'm not sure yet, because most of the bills we've pushed have zero budgets associated with them. So we don't really have any money for implementation or blending it, which has made things, that's the reason we were able to get the bills through. But it's I'm honestly, I'm not 100% sure how it will go. It all depends how the Republicans push our current health bills and our Medicaid reform through the legislature and see what happens next. But we're patiently waiting to see how things go down.
Thank you. Roseanne, you get the last word.
Thank you. Well, I would echo what Matt said. This is a real chance. There's a lot of opportunities that are going to come up with this, but there's also, as Matt said, a lot of concerns. We're really grappling with this. There's a group that works on this statewide, and somebody from my office goes to all the meetings. We're in touch with the various syringe access programs. Trying to help them figure out or have them help us figure out, what this means to them. And the frightening part is there isn't a lot of clarity about that, how they're going to be able to possibly bill for some of the services they do, or whether, there's a real concern, I think, nationally that this could be a real downside for syringe access programs if they don't find a way to fit into this. And so, it's a lot of challenges and a lot of concerns, and we are grappling with it every day.
Can I say one more thing real quick about that? I'd say to anybody thinking about this, the biggest potential downside is the potential for this to completely annihilate our history of anonymous and confidential services. It's something it's the main thing that makes me really, really reluctant to get involved. And it's the main thing that I think means that, never at least I hope, will Medicaid or something like that become, the primary or sole funder of harm reduction services. I think that leads us down a very bad path and undermines a lot of the work that's been done for years and years. We're actually running right now a community-based participatory research project where we're doing focus groups with syringe exchange participants on exactly this subject, kind of asking them their opinions about all this. And then Vocal and the IDUHA, which is the New York City Harm Reduction Network, will be putting out a white paper on this subject within the next couple weeks. And also, the Open Society Foundation's funded through Brandeis University to do a paper on this with a national perspective. So if people are, really trying to figure out some of the ins and outs of this, both the sort of ethical sort of issues that I was just talking about a minute ago, or the real nuts and bolts of how would you construct billing around harm reduction or whatever, there should be, new resources like that coming on, coming out pretty soon.
And we will definitely distribute them as they come to us. So thank you so much to our panelists today, from strategic use of media to law enforcement allies to base building and user mobilizing. All of the strategies that you use are both inspired and inspiring, and so thank you for sharing them with us. For all of you participants, thank you so much. Again, this is audio recorded, and the PowerPoint presentations will also be available if you email us. We will let you know. We will send them to you or to anyone you know who is interested who couldn't potentially participate. And also, finally, so this is the fall series of advocacy of harm reduction webinars, and it seems like there was interest, but if you have any critical feedback for us, please do send it on, or if you're interested in more of these happening in 2014, also let us know. So again, thank you for your participation, and thank you so much to our panelists for joining us today, and harm reduction forever.